Thank you all for joining, and I will now introduce today's presenter. Dr. Rita Lee is a professor and associate division head for education in the Division of General Internal Medicine at the University of Colorado School of Medicine. She received her medical degree at the University of California, Los Angeles, and completed her internal medicine residency training at the Cleveland Clinic Foundation. She has a passion for medical education, leadership development, and advocacy. She serves as the director of HEAL for the Anschutz Medical Campus's Office of Access and Engagement, which provides consultations, trainings, and community circle facilitation to foster equity, inclusion, and belonging. Rita has also been instrumental in building and developing the new equity-focused health system science curriculum for the CU School of Medicine. Thank you, Dr. Lee, for being here with us this afternoon. I am going to stop sharing my screen and turn it over to you.
Great. Thank you so much for having me. I'm excited to be here with you all. And let's see if I can get this correct. It always works in your tech check. All right. Hopefully I am showing the correct presentation screen. All right. So our learning objectives for today are to describe the challenge of inclusion and access within kind of the research enterprise, and then to describe strategies to increase diversity, fairness, and inclusion in research at each stage of the research life cycle. Before we get started, I always like to begin with some community agreements, and that is how we want to work together as a group to create a space for discussion, dialogue, and discourse. And I want to just start with some confidentiality. Again, I want to create a space where, we can actually potentially ask questions in a safe environment, share stories, etc. And the hope is that whatever is said here kind of stays here. But lessons learned should be shared broadly. Our hope is that you'll be present with an open mind and an open heart. And really, my goal is to create a learning community. This is not about trying to label people or things as good or bad. It's not designed to create a sense of shame or guilt, as that does not actually serve our purpose. Our goal is to really foster a brave space where you can engage more if your tendency is to sit back, listen more if your tendency is to share, and really, again, learning together by leaning into some of that discomfort and engage and listen for understanding. So before we get started, I just want to quickly review a couple of important pieces of terminology. And so I want to start by talking about diversity. So the way we define diversity, it's really about the numerical representation of faculty, staff, and students who hold individual differences such as personality, learning styles, life experiences, etc., as well as group and social differences that may be based on race, class, gender, sexual orientation, country of origin, ability status, political, religious, or any other affiliation. And the reality is like when we think about it, is like if you exist, you are part of diversity. And some other terminology that's important to know is the difference between equality and fairness. And this graphic can help us understand those differences a little bit better. And what you can see in this graphic is that these individuals are all of the same height. And this symbolizes that they each have similar potential to achieve their goals and to be successful. And in this case, success is depicted as the ability to see and access the scenery that is beyond the fence. And what you notice in the graphic is they are not standing on even ground, and therefore the fence might be taller for some. And this demonstrates that different people have various barriers to achieving their goals. And these can be structural barriers such as discrimination, socioeconomic status, and access to opportunities. And when we think about equality, basically that's giving everybody the same box. And what you can see on this very left side of the graphic, providing everybody with the same box will allow the person in purple to see over the fence, aka achieve their goals, but the person, in green and blue still do not have that access. When we think about fairness or equity, it's really about giving people what they need to succeed and leveraging their strengths. This includes accounting for the barriers that we have created, which again are depicted by those uneven ground and the fence, right? So when we think about as an example of saying, for example, individuals who are left-handed, you know, We don't go around saying, oh my gosh, you are incapable of cutting paper because they are running around using right-handed scissors. We actually give them scissors that are designed appropriately to be left-handed scissors because they are equally able to cut paper when we give them the right tools. Okay. And it's really the focus is on leveling that playing field so that everybody has that same access to opportunity. And this third pane in this graphic is really what justice would look like. And that's when we remove all of the barriers that we have created that prevent everybody, right, from reaching their goals. And it means going into community and, right, dismantling some of those barriers that cause limitations in our abilities to access our goals and achieve what we want to do. And so the other important topic is inclusion. And inclusion is the active and engagement, intentional engagement with the diversity that we have, with all the people that are on our team in decision making, program development, understanding what things mean, sense making, writing, implementation, etc. Right. And it's a way that we really do our best to try to avoid tokenism. Okay, and that's when we ask people to represent an entire demographic without allowing people to be their authentic selves or necessarily wanting to hear their voice. Okay, when we think about inclusion, it's really about how can we benefit from the wisdom, the knowledge, the talents, and the perspectives of everybody in that group. Okay. So when we think about this, looking at that big picture, this is our socio-ecological model, right? Saying that like we all live in a society and these structures that we created for ourselves as a society, that's our laws, our policies, our built environment, access to resources, the communities we live in, and those shape kind of our interpersonal interactions as well as our individual level kind of knowledge, motivations, and sense of agency. And the reason that this is important is that, we know that traditionally research has not necessarily included, right, diverse populations in what we've studied. And so that limits kind of where our evidence base is and our ability to make interventions as well as achieve the health outcomes that we actually want, right? And this is from the NIH website, the All of Us Research Program, right, stating that by studying data from diverse groups of people, researchers, we can actually learn more about what makes people sick or keeps them healthy. And that actually allows us to do better research for better treatment and disease prevention for every single one of us. And so why are we talking about this, right? When we think about historical perspective, we know that research has not always included all of the various populations that are mentioned and critically important in that All of Us website. So we know that for many, many years, a lot of research studies did not include women because of concerns about impact on pregnancy for different like medication treatments, et cetera. There's also been a historic mistreatment of different groups of individuals in research, right? Thinking back to Tuskegee, thinking about the experimentation on Jewish individuals who were in the concentration camps during the Holocaust, right? And we've also had lack of inclusion for individuals who may be living with a disability or for LGBTQ plus individuals to self-identify as being part of one of those dimensions of that impact somebody's health. When we think about those strategies for improvement, right, this follows that socio-ecological model of when we think about that interpersonal level, we can understand different belief systems. We think about the institutional levels. How are we going to rebuild trust with our community members? At the community members, right, it's involving people, and then also at the public policy level. So one way of kind of approaching this is thinking about it through that research life cycle in terms of trying to optimize access and engagement. Right, so the research life cycle is that heuristic model for understanding the various steps in the process of scientific discovery. And it's often represented in that wheel to emphasize that continuous nature of research with one project kind of leading into the next. You all probably know this much better than I do, right? And the way I like to think about it is like the steps of the life cycle include like the planning process, the acquire process, aka how are we collecting data, right? What's the process of collecting that data? How are we analyzing it? How are we preserving the data, sharing results, and then reuse for the next time? Okay. And the first thing again is to think about like that team. The research team really should include members with diverse perspectives and backgrounds, particularly those from the communities that we're actually trying to serve, as well as those who have experienced inequities in health outcomes. And that allows us to identify what are those priorities of those groups, right? What are the potential unforeseen harms in doing research with particular communities? We want to be sure that we have intentional mentorship and sponsorship of team members from broad backgrounds. And again, it's also important to follow that data to understand which populations may have the greatest needs, and strive for inclusion of those populations within the research team itself. We also know that the entire team should undergo training on implicit biases as well as strategies to mitigate that impact. And we also want the team to have reflexivity. In simple terms, reflexivity is that process through which a researcher recognizes, examines, and understands how their social background, positionality, and assumptions might affect the practice of research. Right? We are as much a product of our society and its structures and institutions as the participants that are involved in the study. Okay. It's also important that team members have equity or fairness in voice in terms of hypothesis generation, study design, implementation, and writing. And this is critically important to avoid tokenism again, where we're just saying we want you to be on the team, but we don't actually want to hear what you have to say. And of course, critically important, and we hear this from our community collaborators all the time, is that they would like community members to be compensated at appropriate levels, similar to levels that the rest of the research team that come from academia are compensated at. And also recognize that it takes a lot of time to build trust with community. They want investment in long-term relationships and partners. We recently heard from some community organizations that they want us to kind of stay with them even when the money runs out. And so that they know that we are here for them and with them, as well as kind of clear roles and responsibilities of what people are going to be doing. And then again, compensation that matches those responsibilities. All right, so when we think about the planning stage of the research, really, we want to include, when we think about hypothesis and study design, we really recommend including community perspective and voice, being intentional about how and why certain data metrics like race or ethnicity might be measured and or included, if it's even necessary, right? Recognizing potential barriers to participation and accounting for them in the study design, right? When we think about data management, we also have to recommend, like, acknowledge that race is only a social construct. It's a human invented term that we've used to describe and categorize people into various groups. And even though it was used infrequently before the 1500s, it was originally attempted to identify groups of people with a group connection. However, when we think about the research aspects of it, these racial groupings that we have invented are actually genetically much more similar to each other than they are different. And so are we using it inappropriately in the research? Like, what are we actually trying to measure? Are we actually thinking more potentially about ethnicity, which is a quality or a fact of belonging to a population group or a subgroup who share a common cultural background or descent? In general, when we think about ethnicity as an identifier, it's usually about shared ancestry, language, and culture. But if it's really a study about genetics, then that's really what we should be looking at is genetics rather than these as different kind of proxy markers for specifically what we're measuring. And then when we think about the use of race and ethnicity in research, we do want to ensure that they are used to address questions directly to related to these social constructs and concepts. We can use them to sometimes represent social experiences, but not biologic facts to explain whatever phenomenon is we are studying. We should allow study participants to define their preferred racial and ethnic identity, as well as other identities like sexual orientation and gender identity. We want to make sure that we're actually collecting complete and accurate race and ethnicity data that maximizes the data richness. Okay, thinking about how are they actually relevant to the study? How will it improve our understanding of whatever this phenomenon is that we are evaluating? Okay, we're trying to avoid use of race or ethnicity to explore physiologic differences. And if our data must be manipulated, we should be using evidence-based data strategies to collapse or combine data to ensure our categorizations properly represent groups or subgroups that are included in the sample. So if the samples, the study sample size or cell size of different groups really should dictate the data reduction strategies rather than automatically collapsing for ease of doing the data analysis. And then again, which categories we are collapsing should fit within the parameters of the research question. We want to make sure that our statistical analyses, again, ensure sufficient examination of, again, whatever that intended phenomenon. And then when we can, we want to conduct appropriate comparisons to examine whether significant differences are within or between different groupings. Okay. And we also want to provide an interpretation of research findings that extends beyond the simple reporting of statistical significance. We want to use potentially the social context of race and ethnicity variables to assign sufficient attribution to social explanatory factors such as economics, trust, potentially biases in how people are treated, etc., that are based in the literature and explore potential reasons behind relationships that take this context into account. When we get to data acquisition, right, one of the biggest things that we hear about is the recruitment. And when we look at the literature, the motivators for people to volunteer as participants in studies is sometimes access to novel treatments for those who might be out of options for their particular disease entity. Sometimes people are looking for better or free medical coverage, particularly those who are struggling to afford expensive care or treatment. Sometimes compensation is a motivator, curiosity to learn more about their disease and improved medical attention. Responsibility, some people will say that they feel a responsibility to represent an underrepresented group. And in a different study, Black participants suggested that medications are not typically designed with them in mind, so involvement in research studies was perceived as a positive change to this pattern of underrepresentation. Okay, so when we look at some of these motivators, we also have to think about like what are the ethics around some of these, especially if they are, using this recruitment into a study as a strategy to gain access to healthcare, right? What are those risk benefit trade-offs for the individual level person? When we look at barriers to different communities participating, there's fear is very commonly cited. So there's fear of side effects if it's a medication study, fear of loss of the standard of care, potentially violating cultural norms, or defying family members who don't want them to be involved in research studies. There's actually some stigma in the community related to being a study participant. There's a significant concern, especially in some subpopulations of data being tracked, AKA like there's a lot of groups, particularly in the LGBTQ plus community and other communities who don't like the term registry. right? Because there's a fear of, will that data actually be potentially subpoenaed or used in a way that is actually designed to harm the community members rather than serve them. And then there's also a lot of misinformation out there. And we also have to consider that historical abuse and historical missteps that we in the research world have actually committed against, like I said, different groups. Those stories kind of continue and lead to, some generational trauma related to involvement with healthcare research. And then there's also sometimes difficulties understanding the FDA and the Institutional Review Board oversight and how that actually works in terms of protecting their health and safety. So when we think about recruitment, we want to make sure that we are actually investing in our community partners as well as our community leaders. Again, that long-term kind of building up of trust over time. And it may involve showing up authentically into community spaces and community events long before we actually make any kind of a quote unquote ask for individuals to be able to participate in one of our studies. We also want to make sure that we're looking at lowering barriers to access and participation by providing things like childcare, transportation, potentially assistance with technology. Again, we encourage you to consider going out into community to begin building those relationships. Um, Also, what has been effective is affiliation with an advocacy organization or an endorsement by a member of their identified community. Sometimes is perceived as an effective way to enhance your sense of trustworthiness, right? If you are partnered with an organization that has a long historical context and has built trust with a particular um, group of individuals, they're more likely to trust you if you have their endorsement. And then thinking about social media. Trust in social media for medical guidance in one study was actually roughly predicated on the age of the participants. So in general, younger participants tend to trust social media a little bit more than older folks. Um, in this study, Twitter and Reddit and subreddits were a little bit more trusted compared to Facebook, which is one of the least trusted. And it's also important to recognize the cycle of mistrust that can sometimes happen, right? So, you know, sometimes what happens is that if you make like negative assumptions about somebody because of that historical mistrust, sometimes that leads to self-protective behavior, which might be observed by the other person as aggressive behavior. And then that leads to negative assumptions and self-protected behavior, right? And so it's like, I'm not defensive. Well, no, I'm not defensive. And then it can end up perpetuating itself. And so sometimes we have to kind of take that moment and be like, are they really aggressive, or is this like, or are they making a statement or taking a stance on something as a means of self-protection in this space, knowing potentially some of the historical context? Okay. So this is comes from a research by Clark et al., where they actually looked at barriers impacting minority patients' willingness to participate in trials. And so these were some of the things that came up were things like mistrust, lack of comfort with the process, lack of information, time and resource constraints, as well as lack of awareness. And they came up with different kinds of solutions and ideas for can we address these particular concerns. Right. So from the patient's perspective, they want us to emphasize that their health and safety come first, including any mentions that the treatment has already been tested, whether it's in animal models or other populations. Informing patients that their health will be closely monitored, consistently showing appreciation for their collaboration and letting them know that you value their participation and that we're always available to answer questions. Highlight that it's essential for all people to participate in trials so that they can actually be useful, and we can apply the results broadly to all populations. They actually recommended creating an information booklet that is free of, our jargon and lingo, that's easy to understand and includes a list of FAQs. Potentially offering to include friends or family members in that decision-making process if that's what they desire, so that it is kind of fully transparent and doesn't feel kind of pressured from our perspective. Offer to keep their primary care provider informed of what's going on, as often that is a source of trust for members of the community. Again, transportation, flexible hours when possible, potentially going out to the community when feasible, and potentially um, one of the suggestions was to create a clinical trial mobile app and or offer to provide a cell phone for patients who do not have one so that they could ask questions and be in contact if they wanted to. They also wanted some training for referring physicians, and so they wanted to acknowledge the important role of again, treating physicians are a source of trust often for community members. Um, Explaining to referring physicians just how little minority participation there is and asking for their cooperation, and bringing them into that process early so that they can also provide information related to inclusion and exclusion criteria. And then sharing those results with referring physicians when it focuses on their patients whenever possible. And these were their suggestions for what investigators should do. So they wanted them to work to create more open lines of communication, emphasize the importance of reading into a patient's situation and responding to that patient's point of view rather than like talking down to them. Again, encouraging the inclusion of all folks. Um, and really trying to meet our patients and our where they're at. Okay. And then the study coordinators are also a critically important part of the team, right? Acknowledging that, the coordinators believe that their role is a key resource for patients during trials, and deferring to their expertise and experience in recruiting for trials, building that trust, creating new opportunities, and supporting them in the work that they are doing. When we think about the process, we do want to think about data collection, again, allowing participants to indicate the categories that best align with their personal experience. Okay, asking multiple different intersectionalities of identities because we are not just monolithic human beings, right? Ideally, the information should be participant collected rather than observer collected, and using a combination of predefined response categories as well as open-ended questions to ensure consistent and comprehensive methods for collecting data. They would like us to be aware that, if demographics are being used as proxies for something else, and then again, explicitly collecting, if we are trying to use this to look at the determinants of health or genetics, then we need to be explicitly collecting data on the determinants of health, genetics, et cetera, whenever possible, if that is the goal of the research. And ideally balancing, qualitative and quantitative data collection. There's been a lot written in the literature about appropriate use of data. Again, so studies that seek to test genetic hypotheses should require collection, analysis, and reporting of genetic data rather than, again, proxy markers. And then, although sometimes biologic predispositions to certain diseases may track with some racial or ethnic groups, we recommend that researchers do not exclude otherwise eligible participants who might have other identities capable of developing the disease, because otherwise we may end up worsening on kind of the under recognition of the disease in such groups. And then the process. They recommend, making definitions, right? How are we defining this? And how are we going to use this before we actually engage in the research process? Trying to disaggregate race and ethnicity data, recognizing that sexual orientation is not the same thing as gender identity, and it's also not the same thing as sexual behavior whenever that's relevant to the research. Acknowledge when data are missing, and using language and terminology that is culturally responsive, and knowing that culturally responsive terminology is constantly evolving, and trying to without necessarily compromising the data collection, but trying to be as responsive to the community to welcome them into the research process as possible. Then when it comes to the analysis component of it, again, ideal world, the evidence base shows that racial and ethnic categories should be used appropriately to avoid this concept of biologic essentialism, right? We are studying the impacts of racism and discrimination. Race is not always biology. Again, if the data must be manipulated, they recommend using evidence-based data strategies to collapse or combine data to ensure our categorizations actually represent the groups that are included in the sample. And again, when they are collapsed, they should fit within the parameters of the research questions. And so if we need to, but we need to explain and justify the manner in which these data groups are actually collapsed and ensure that the individual groups within each category are easily identified. And we want to align our statistical analyses of the different identifiers, again, with the research question to ensure that we're actually examining the intended phenomenon here. Okay. If you all are interested, there's a phenomenal book by Deborah Stone about counting, and it's about how we use numbers to decide kind of what actually matters and how sometimes, how we look at numbers and how we're collecting data could actually provide kind of a skewed analysis based on where that information is coming from. And then when we think about the interpretation piece of it, again, interpretation of results should always include community voice and perspectives. We want to make sure that we are involving community expertise in considering the impact to current knowledge. Like, what is their interpretation of the findings? And how do they feel that this is relevant to their particular community? And then preservation. The preserving of the data. So there's a lot, again, around data security and retention, recognizing there is so much historical mistrust in certain communities, particularly in a time where certain communities are getting essentially targeted by current policies and or the rhetoric that is in the broader sociopolitical landscape. And we want to make sure that we have transparency on data use, security measures, as well as the retention of the data. Who owns the data? Often when we have conversations with community groups, they want to know, do the researchers own the data? Does the community own the data? Who has access to the data? Can the community, right? If the researcher holds the data, can the community ask for the data whenever they want? Right? Will that ever happen where, that data could be potentially released to different groups? And when would that occur? And then if mistakes or data breaches do occur, we recommend the authentic apology. And that is saying, this happened, we acknowledge that this happened, and we acknowledge this is the impact on the community. And we sincerely apologize for that. What steps are you going to do moving forward to reduce the risk of a repeat event happening, and or what steps are you going to do to ameliorate the impact? Okay. And then also, again, that accessibility of the context, the feeling like that information is freely available to them in an honest and transparent way. And then sharing the results. So when we think about data dissemination, it's an intentional plan on sharing data with impacted communities as well as community partners. When relevant, ideally including strategies for implementation of what was learned for the benefit of those underserved communities, right? Trying to develop an effective communication plan, right? Is it going to be a publication that is going to be in a journal coupled with some sort of an informational document that is going to be distributed to the community members that is written in a language that they understand, or demonstrates the clear impact that the research findings have on their health outcomes. When we do get to this thought about writing for journal publications, we want to make sure that we include appropriate authors, including community members whenever applicable. And some community members are like, yes, I definitely want to be on the paper. And others are like, I don't need to be an author on the paper, but I definitely want my perspectives included in that publication. And then again, being clear about the root cause of any health inequities or disparate health outcomes that might be found. Are these based on determinants of health? Are these based on systems of oppression or experiences of discrimination or bias? Um, and this is a quote in the interpretation section: for studies that highlight associations of race and ethnicity with health outcomes, authors should discuss how their findings illustrate the intersection of race and ethnicity with other sociodemographic factors in the health context being studied, the role of structural racism in this context, and how this might be addressed. And again, when we're looking at our citations, we want to make sure that we are citing relevant scholars who have a wide range of perspectives and backgrounds that kind of inform the overall picture of what may be actually going on, recognizing that there's multiple truths. And then with the writing, we always encourage patient-centered language. So terms that imply a hierarchy among the races, aka like non-white, should probably be avoided, and preferred terms like underserved or underrepresented populations should be used instead as contextually appropriate. They also recommend listing of racial and ethnic groups in tables should be ordered based on an empirical rationale, aka like alphabetical order, rather than one that implies a hierarchy. And then naming racial and ethnic categories as specifically as is appropriate to the study context is preferred over the overuse of different collective categories. For example, Indian may be suitable in the context of some research questions, but in other contexts, Punjabi or Malayi may be more relevant. And then, Asian is generally too generic to be sufficiently informative. There's multiple different groups that fall under that very broad Asian category. Racial and ethnic terms should also be used in adjective form rather than in noun form, so they are Hispanic people, not Hispanics. Again, names of racial, ethnic, or tribal groups should be capitalized. And then we are also recommending contemporary names and language, again, recognizing that terminology does change over time. And if there is a historical context, for example, if you were doing like literature review and historically the terminology was different than it is now, right? A statement to that fact, like we know that these are old terminologies, but this is what was used in those studies that we are citing. And that's the only reason we're using those. And the current terminology is what we're actually going to be emphasizing in this current paper. And again, as much as we can lean into the different communities that are represented, hopefully on our research teams, we want to lean into their preferences as much as possible for the language that we are using. And with that, I have listed a few resources for you. And there is also in the Journal of General Internal Medicine, a anti-racism throughout the research life cycle that I relied on quite a bit for this particular presentation. And I do want to acknowledge the Society of General Internal Medicine Research Interest Group, the SGIM Anti-Racism Work Group, Angela Sawaya, Channing Tate, and Demetra McNeil, who all helped me kind of create this talk. And with that, I've got plenty of time. So let me end the slideshow and see if there's any questions or discussion?
Thank you so much, Dr. Lee. We do have a question that was submitted, and this person was specifically interested in your thoughts on the gap between research cycles and how you can maintain engagement when one project has ended, but the next one may have not yet begun.
Yeah, I mean, I think for a lot of individuals that can be a challenge. I think when our communities talk about having us continue to be engaged with them, I think historically we drift in when we have an ask, and then we drift back out when like our project is over, and then we drift in when we have an ask. What they are actually asking that we do is not necessarily engage with them in terms of continuing to do research, but continuing to engage with them in dialogue, or potentially like volunteering at community events. And so I know that would definitely require an investment of time. Um, but that is actually what builds the stronger relationships with them. For example, I'm not actually I don't do much research, but I have worked quite a bit with, for example, like One Colorado, and we actually have an ongoing dialogue, of like, what is it that you need? Is there anything that you need from me at this point in time? Can I help? I've helped edit little documents here and there to make sure that they're accurate from a medical perspective. And so because we have this bidirectional kind of ongoing relationship, when I do have researchers who are interested in working with this community, I am able to, I have that trust that like I can reach out then and say like, here's what's going on. I've talked, to this researcher about this particular project. Um, I do think this would be potentially of benefit with the community. Is this something that you think you're willing to help us with supporting with like a letter of support as a community organization, potentially outreach to the community connections that you have, et cetera. And so that's kind of been that longer term kind of relationship that I've built over the last several years. And I don't know if that's helpful or responsive.
It's great, thank you. And as people are typing more questions into the chat, I did want to go back to a piece that you mentioned earlier on in your presentation on the voice of research teams. So we have a lot of, or we have a great group on the call with us that work on research teams. I'm wondering if you have any advice on how research team members can approach investigators on these topics and maybe educate them on different resources that are available. For example, the Cancer Center has a community advisory group for research called COE Cares. So I'm wondering what advice can you give to initiating these types of conversations between research teams and investigators?
Mm-hmm. Yeah, that's a great question. I mean, I think, I think that ongoing dialogue, right? A lot of it is, when we're trying to advocate or message things, it's always like, who is the audience, and like, what do they care about, right? So our investigators care about high quality research that is ideally, right, the broader the dissemination, the better the journal, the broader the audience, and the broader kind of the impacts of whatever research outcomes they're looking at, the more likely they are to get in like more prestigious journals, et cetera, right? Like, again, every individual has different things that they care about. And so I think leaning on that and saying like, look, we should probably involve our community advisory board, in looking at like, is this a question that resonates with the community? What do you think about involving them in thinking about the research design at this point in time? The literature, right? The evidence base shows that involving community at multiple steps in this research life cycle will make a better study, right? That will actually improve health outcomes, which I think is most investigators' goals. Ultimately, in that space, I think leaning into that piece, I think can be helpful.
Excellent, thank you.
Of course.
On the topics of journals, we have another question that was submitted. Do you feel journals have been receptive of individual group terminology when presenting data in manuscripts?
I'm not sure I understand the question. Sorry.
Sure, I can read it again, and
Yeah.
if this person feels comfortable jumping in, please feel free. Do you feel that journals have been receptive of individual groups' terminology when presenting data?
Oh, like if it's, I mean, I think it depends on what individual group terminology. I guess that's what the words that I'm getting a little bit stuck on. If it's,
If it
like
helps,
it,
they added, I'm sorry, I didn't mean to
yeah,
interrupt.
no,
They
no, go
added
ahead.
an example of using white versus Caucasian.
Hmm. Yeah, I mean, in general, there is some generally more accepted terminology, like the current recommendation in general is white over like Caucasian because most people who are white don't actually originate from the Caucasus, because that was actually a very specific kind of geographic subgroup. Um, and I think if there is in the explanation why a particular terminology, like if it's like this group, right, the population that we studied, these were the demographic factors that they, in that evaluate in the design process that they group wanted, then I think um, that journals are generally more receptive in that manner, if that makes any sense. A lot of the different journals also have different teams that are working on improving the actual like kind of equity in the quality in the way that papers are presented, if that makes sense.